You're
Um,
great.
so this is our patient for team one. His name is Jonathan Kennedy. And I can give you guys the MRN afterwards. I'm not allowed to put it on a PowerPoint. But going into it, he is a 4-year-old, 1 month old boy, presenting for kind of trifold reason: outbursts, violent behavior towards his sisters, and anger issues. That is information I actually got from, he was referred in 2020 because of concerns from his mom and from his First Steps evaluator. So he is in First Steps. And then it sounds like the behavior has continued into 2022 now. So that's as much as I know about their referral. There isn't a lot in the chart, so bear with me, but additional concerns that I got, thankfully, from MARTA included sleep issues. So he takes 10 milligrams of melatonin, pretty hefty dose for a 4-year-old.
I'm sorry, Abby, really quick. I just realized that there's somebody on that I don't recognize. Jamie, are you there? Is Jamie not one of our Len trainees, but with a different name, right?
It's Jamie Donovan.
Jamie Donovan, sorry.
I had
Okay.
to block my phone. Sorry.
You're fine. I was just like, Jamie, not a Len trainee. Yep. Okay, Jamie Donovan. Thank you.
You're welcome.
So additional concerns included sleep issues. So he takes a hefty dose of melatonin. And then also mom reports that no one can watch him because of his behavior. So there may be some concerns about like safe caretaking because of his kind of outbursts and things like that. So that may come up additionally too. When I went through his chart, so this is what I could find. There wasn't much because he hasn't been seen much in our system. But birth history wise, he had a cystic hygroma prenatally, which is like a lymphatic malformation in the neck region. It looks like that might have resolved prior to birth. He was born full term via C-section, secondary to breech positioning. Otherwise, he was, I think, like 8 pounds, 7 ounces when he was born, so a good size, and he passed his hearing screen. So past medical history wise, what I know so far is that he had recurrent episodes of otitis media, so ear infections, and then also tonsillar hypertrophy. And then additionally, he has ADHD. I didn't see that in the chart, but I got that from MARTA. And I'm not sure who's taking care of that. I'm guessing his pediatrician. Past surgical history wise, he had PE tubes and a TNA in 2019. Family history wise, I got this from both MARTA, but also from his birth record, so things could have changed. But mom has ADHD, anxiety, and bipolar disorder, and then dad also has a diagnosis of ADHD. And then social history wise, I don't know about his parents' situation. I know that mom is involved. I know that he has 3 siblings, an 8-year-old, a 2-year-old, and a 6 to 7 month old, and one of them at least is a sister. I'm not sure if all of them are. And then little things from chart review that I got. This may only be helpful to PT, but he was seen by orthopedics in 2019 for right ankle swelling and hesitancy to bear weight on his right foot. He had x-rays that were unremarkable, and they did recommend external PT for strengthening and follow up in 6 months. I didn't actually see a follow-up, but it looks like maybe he did get PT outside of our system. He was definitely in First Steps because I saw that in the initial eval, and then he was also in Head Start. So, but I think there's a lot of concern about his behavior and how he's going to do in Head Start and school and things like that. And that's all I got. Any questions that you guys have? Stop sharing. And I can give you guys the MRN if you would like. I don't think Steph, I'm probably not allowed to put it in the chat, am I?
Did we do that before? The chat
I don't
gets
think
deleted, but the MRN is the medical record
Oh, I'm
number.
sorry.
Jason.
Yeah,
Sorry.
that's how you look him up in Epic. So his name is Jonathan Kennedy, and his MRN, whenever you guys are ready, it's like a group of 40, so I'm gonna think you're ready, is 117-07546. And there isn't a lot in there because he's not really in our system. First Steps, good question. First Steps is EI, early intervention for Kentucky. So he lives in Kentucky.
Hey,
You
Abby,
know
would
where
you
in
mind?
Kentucky?
He was, oh, I don't know, Marta might remember better than I do.
Abby,
Yeah.
while she's pulling that up, do you mind just reading the MRN one more time? I just want to make sure I have the right one down.
Yeah.
Thank you.
117-07546. And I think Jonathan is spelled differently from the Jonathan that was written in my email from Marta, but
I feel like Jonathan has an extra letter in it.
yeah.
When I'm looking at it, John Austin, J-O-H, Joe Nathan, J-O-H-N-A-T-H-A-N.
So we may need to confirm how his name is spelled.
Yeah,
'Cause
Mom
that's
has
an
not
I
corrected
mean,
me.
yeah.
They live in Ghent. I don't know if that's how you say that either. G-H-E-N-T is the city in Kentucky. Carroll County, she said it would be at least an hour and a half to us. And she knows they're all at 8 a.m.
Yeah, it's pronounced gent, but yeah, it's pretty far down there. When you're saying he has outbursts and then
Yeah.
it's towards the younger sister. So is it towards the baby?
I don't know, Marta, did they tell you which, it doesn't specify in the referral.
Towards all children, including the baby.
Towards all of them. Okay.
The baby was 6 months when I first talked to Mom, so I feel like the baby should be like 7 months now.
Abby, I thought I read Dad may have some legal troubles and possibly incarcerated, but I'm not sure if you saw that.
I think I did see that actually in a 2018 note from neurology, maybe. They
Okay.
had that briefly and I didn't see it replicated. I think I did see that in one of the notes. And then I didn't see it. We only have like 3 notes to go off of, really, like lots of encounters. So it's possible. But I don't know, Marta, if they mentioned that to you.
Thanks.
She didn't mention anything. She just said, we are committed. We will come. But we never talked about who that entails.
Marta, is this the family that we found out about through?
Yes, you sent them to us in the fall. Mhm.
Yeah, so Mom is, I actually got contacted by one of our institutions, physician liaisons. And they were basically like, can Cincinnati Children's help this kid? And I'm like, DWP actually can't, but the LEND program maybe can, but they would have to wait till the spring. And Mom has been like super interested in this all the way back since like October. So she's really invested, I think, in getting help and has a pretty decent primary care team that is supporting her.
Abby, you mentioned there were like 3 notes. What specialty areas has he seen?
He's seen ENT for his ear tubes and for his tonsils. He's seen neurology in 2018 for fussiness. He had benign macrocephaly, so just a big head, essentially.
Okay.
And then he saw orthopedics for the right leg hesitancy.
Thank you.
Yeah.
I have a quick question. If it takes an hour and a half to get there for 8 o'clock appointments, is there any thought on how it may impact his performance or his testing?
It's a good question.
Mom was so desperate to get help. She said she doesn't care. She does worry a little bit that they might. So if he's 15 minutes late or something for your eval, I wouldn't be too surprised. But she's so desperate and feels like we're the only people who are going to be able to give her answers because no one around her has been able to help them figure this out. That she doesn't care about the distance or the time.
Also, maybe have some breakfast available from your snack. What's that called? Little kitchenette?
Nutrition center.
Nutrition center. Have a little breakfast.
Those fruit
ready
snacks
for
are
him.
highly nutritious. And
Hey, and
delicious.
Pop-Tarts.
And Pop-Tarts.
There's cereal in there.
And it looks like it could be an hour to an hour and a half for them. So there are ways that, I was trying to figure out directions for how they could come. So at least there's more than one direction for them to come if there's one highway backed up.
90 minutes can be a good nap time in the car too. You never know.
Well, I'm also looking at the fact that he's 4 and he has a 2-year-old and a 6 or 7-month-old sibling. So are the other 2 siblings going to be coming to the appointments? So is there a possibility that mom's going to have all 3 kids?
She did not say. Mom did say she's taken off all of these days and that she normally works. So she might have childcare arranged already. But she didn't say either way.
I would prepare yourselves for having multiple children. However, just based on what I recall, the conversation was that I think mom brings all the kids to the appointment and they see his behavior at the appointment at the pediatrician's office. Actually, I think he sees a nurse practitioner in their area, but I'm pretty sure that's who I talked to. And they do see the aggression in the appointment with the siblings and just the tantrums and whatnot.
So where available, can we consider Child Life as well and have them available? You know, just, I don't know who all has it or what days and what times, but just keeping that as a consideration going into this of keeping Child Life aware that this might be a good family that we need additional assistance.
I think that's a great point, Nicoletta. We have had Child Life on our team before in Lend, but since we don't this year, I think it's totally appropriate to request Child Life support just like you would normally in your clinics.
Just out of curiosity, I feel like I have a general idea of what Child Life does, where they just kind of talk to the families and help prepare the kids. But that is just from reading their notes. If someone could give me a explanation of like what they do as Child Life specialists, that would be fantastic.
I'm just going to say as a parent, when Maddie was in the hospital, they brought games to the room for her to do whatever she wanted. If she wanted a video game, if she wanted a tablet, if she wanted a certain movie to watch. Back then, they were just videotapes. There wasn't, automatically just picking up on the screen now. Very active, would take them down to the Child Life Center, let them play down there, color, whatever she wanted. They were great.
So we officially only have them at Liberty and at Base, but they can support any appointment. They are very active in the surgical and post-surgical units, pre and post-surgical units, and then in appointments where the child might need some additional supportive distraction, they help out with Botox appointments in PM&R. And I believe they obtain master's degrees. Isn't that correct? In order to be credentialed. So
they obtain a master's degree afterwards. I believe it was 2 years. I'd looked into it before medical school is an option. So more people can jump in, but a lot of times they're well-versed on different approaches on how to help children, exactly what you guys have kind of heard already, be it musical, be it physical. And a lot of times just trying to talk families through, or for us, it turns out being distraction and trying to help with those disruptive patients, unfortunately. So I feel like within developmental, we don't get to see the full breadth and benefit, like Sally was kind of mentioned, that you get to see more in the surgical post-operative units. Because a lot of times with them, they'll use dolls or other tools to help talk the child through, prepare them through, show them what's going on. I know they have different distraction techniques as well for like IV placements and procedures. The funniest story I remember is they had one that the kid was a flautist and they were trying to have her blow bubbles and they were wondering why she wasn't blowing bubbles, and it's because she was blowing down instead of straight like you normally would. So they're taught all kinds of different things that you wouldn't necessarily know. I don't know if anyone else can chime in or help, but that's kind of what I know.
We had great experience too. We had it before the tonsil and adenoid surgery for my daughter, and they came in and they showed her, because they were going to put the mask on her, the gas mask. They did it with a stuffed animal, and then they made it as a hat, and then so that way she could kind of play with the item, and then it would feel much more comfortable when it's coming near her face. So I love everything that they do.
So sometimes, Child Life is physically located in the 3430 location. That's where they have a lot of their services. And so when we know that we have a child who may benefit, you can ask for those services in advance. For audiology, there might be kids who are really concerned when we're making ear mold impressions. Child Life usually has visual stories that they will associate prior to programs and give families picture books of what the family can use to express what's going to happen in an appointment. Oftentimes, our support from Child Life will simply come up to the waiting room and offer big waiting rooms games to play so that siblings are, prepared and that they have something to do while waiting for other kids. And that's, I think, where this kind of conversation came up of, if we have siblings involved, can we have a representative of Child Life, quote, be in a babysitting kind of service for the other children while we're working with that one child. But we do have to request that service in advance if we are looking for that kind of support for the siblings.
And Kim, for OTPT, we can actually put in an order set to request assistance for Child Life. I think my question is whether they will serve in this capacity for like the sibling support. I feel like we've tried to reach out and request that in the past, and that's been turned down for that reason.
Correct. They do not provide like childcare support, babysitting support, even of like our patients. So every now and then, for us, sometimes in like a highly sensitive abuse situation, we're able to get Child Life to remove the child so that we can have a more in-depth conversation with a parent, especially if like the parent and I are calling children's services together in the clinic room. But even that can be hard. They're not there. They can't babysit. They can't provide childcare. They have limited capacity. There used to be 3, now we have 2 in DDBP. And they also have this other role of these adaptive care team plans and creating plans for kids who are seen all across the hospital. And so our 2 do a lot of that work as well outside of their clinic time. So I think that if you think you're going to need support with the patient in the visit, you could ask for that ahead of time from our Child Life team. If you don't know who they are, how to reach out to them, we can help you make some connections.
Can I ask what the difference would be to request Child Life versus behavioral support? Like when you would use one or the other?
Like the behavior support team, the
Yeah.
BST. So Child Life is a part of the BST. So there are Child Life specialists in the BST, in the behavior support team. The BST is just coming to ambulatory. They've been really just inpatient. So that's been a piece of it. Was BST was inpatient, Child Life was outpatient. Now it is possible for an outpatient visits, children being seen outpatient, to have a BST that includes some Child Life support, but if it depends on what the support is needed. The BST plan will say who provides what level of service. So is it a mental health specialist who's accompanying, or behavioral health specialist, is it Joe and them accompanying the child into the room, or that might be named a Child Life specialist. But the plan should indicate who the people are who can do each of the services, each of those interventions in the BST plan. And then an ACT plan is found in the same place of EPIC. So if you know where to find a BST plan in EPIC, then you know where to find an ACT plan.
Okay.
Kelly, I can also show you later, but we have a job aid that goes through the order set for all 3 of those things for us. It kind of helps with the decision making between the 3 of those as well, between the ACT plan, the BST, and the Child Life.
Got it. I was going to say I requested BST based off someone guiding me through that, so I was just curious what the other ones were.
And it sounds like for this kid, BST is definitely appropriate.
Do they
Now,
know?
what I was going to say was, what I noticed is when Grace is inpatient, we have BST services. But if we're just going to a doctor's visit, then we have Child Life services. She is on the ACT plan, so whatever we there, somebody is there to support us. But usually BST was more of an inpatient thing for us. Or if she was having a procedure, they would be there. But if we're just going to the dentist or something like that, Child Life always comes for her.
And we're hopeful that we can get BST and outpatient visits as well over time, hopefully.
That's all I got. I don't know if anyone else has any other questions. You guys have had really good questions so far.
Yeah, really good discussion, guys, and led to a broader discussion about what some additional supports are throughout the hospital. All right.
The only thing I'll add really quick is if we are worried about aggression, making sure that you check in with your supervisors or whoever about any kind of personal protective equipment. So any kind of sleeves or, I mean, obviously everyone's masked and goggled anyway for spitting, but just making sure we're all protected.
So
we don't
along
have
those
to call
lines-
803 safe and wait on hold for an hour just to tell them
Along
we got.
those lines, Stephanie, so like in our division, if an occupational therapist saw a child, there's a whole screening they would do that asks very specific questions about whether there's an elopement risk, whether there's a biting, scratching, hitting, or throwing risk. And then it populates a field that reminds us what PPE to wear for protection. I'm wondering in this case, if it would be helpful to go ahead and establish an ACT plan, to ask Child Life to call the family and ask what helps this child manage appointments better, what we can have as a support. This might be a kid who doesn't wait well in a waiting room, and we need to be ready to go right when they get there. We might find out that scratching, hitting are frequent, and then we would all know what we need to wear, and then we should share that with everyone. That would be my my plan. Thanks, Lindsay.
Do you need me to reach out to child? Like, I'm down in clinic all the time, so I could just stop and ask and tell them a heads up. I just need to know. I think I can find the dates of the first evaluation, but I can talk to Child Life tomorrow about it.
I think it's next week. And it looks like it's with Lindsay Mays and the psychologist. And so Lindsay's actually offering to ask those questions and then share with the group rather than doing an official ACT plan with Child Life. And then that the psychologist can share with us. How do you guys feel about that? So
I think it would be nice to have the ACT plan in the system so that everyone has access to it in the medical record where they're used to seeing it personally, but
I also think that would be helpful for our trainees to see the plan in place, what it looks like in the medical record. And Abby, if you are reaching out to the family, you know, we all know that things happen and sometimes siblings need to come along, but if we can have that reminder, if childcare is available, it makes a big difference in the parent being able to support the individual child and not have to direct their attention away. So if you know, knowing that there are other siblings, if we can make that reminder, if at all possible, not to have our siblings accompany.
Okay, I can ask Child Life then and see if they would be able to reach out to the family before next week and set up an ACT plan.
all right, very good. All right, so that's for team 1. Andrea, are you ready to present for team 2?
yes.
Perfect.
One second. I'm trying to see how to share my screen. I forgot. Oh, it's there. Here's the green button. Can you guys see my screen? Okay.
Yes.
So this is our second case. Our hero name is Cooper. And we don't know much about him, so I kind of grabbed everything from the chart. He's a 4-year-old Caucasian male, and the main reason that he was referred to as is because of the family concerns for autism. I talked to Lindsay, and one other thing that I didn't include here is that he is actually
His father, I believe, works for Cincinnati Children's, and his sister has a history of autism, the older sibling. So what I was able to gather from his chart, a little bit about the prenatal history, uncomplicated pregnancy, mother received complete prenatal care. Mom had a history of obesity and asthma. About his birth history, he was a preterm delivery at 36 weeks, C-section, no further complications during delivery. He did not require a NICU or special nursery care, and he was discharged post-delivery 4 days. Then regarding the family history, couldn't find anything about his dad on the chart, but the mother, as I said before, had obesity and asthma, older sibling, a female with a speech delay and autism spectrum disorder. Personal history, eczema, and a recurrent otitis media. He actually got surgery, so he got ear tubes in 2019. And that was basically it. Then he is followed by a pediatrician, and the parents have been the different case from last time, in which we didn't have access to the chart, but I was actually able to see all the visits that the father or mom took him to, and he went to all of the well child checks. And when I went over every milestone that usually the templates of the provider have, that they are recording if there is any delay on them, and all of them have been normal. At the 15 well child check, there is the option for the MCHAT, but it said not provided. I went to the scan documents too, and I couldn't find anything. So I don't have an MCHAT for him. And for the people, I think maybe the majority of us know what the MCHAT is, but the MCHAT is just a tool that it helps us with questions regarding screening for autism spectrum disorder. And they ask about parents, about speech, about interacting with others. And that wasn't there. And then regarding the growth, his weight always ranged between 60 and 90 percentile. The length was 90%, and head circumference was also normal too. And a couple questions that were raised for me when I was reviewing this chart. He got a request. There was a request for allergy and immunology in 2019. I think because he was having problems with not being able to tolerate some foods, so food sensitivity. I don't think he followed up with that. I couldn't see a note from the specialist. He did follow up with the ear tubes he had them bilaterally. And from the primary care doctor, pediatrician, I did not see any concerns, except that it says message from family requesting a psychology evaluation on October of last year for concerns of behavior problem and a speech delay. And that was it. I did not find anything else for him. And like I said, when I was reviewing every chart for the developmental milestones, I did not see any concerns from the provider about that. And I didn't find an MCHAT on file. All his labs, like hemoglobins, and lead, and all of that was done at 1 year old, and everything has been normal since. That's all I have. And then I was trying to remember what 4 years old do, and I thought this was nice. But do you guys have any questions for me?
I had a question. It supported that he was discharged after 4 days with no other notes about his delivery. That seems like a longer time to be in hospital with mom. I mean, there might not have been any notes to support why he, typically it would be 24, if not maybe 48-hour stay, not like right now, in and out, you're out of there. But 4 days does seem a little bit longer than normal to be staying in the hospital for a typical delivery.
Yeah, I thought it was because his weight and breastfeeding. I saw the weight kind of decreasing, and she saw breastfeeding specialists a couple of times when she was in the hospital. They ended up not breastfeeding and ended up going with formula, and his bilirubin was a little bit high too. Didn't require like lights or anything like that, but I think that was why.
That makes a lot of sense. Thank you.
Yeah, thank you.
Andrea, I didn't catch this patient's name. Could you repeat that one more time?
Yeah, I cannot, it's Cooper. I forgot his last name. 1 second. I have it here. Yes, it's Cooper Bauti. I don't know if that's how you pronounce that. Is a Baute? And if our team is interested in the MRN, if you guys don't know it, is 11 68 6938. Date of birth 9/5/17.
James, can you provide some more information about what you found regarding the Vanderbilt? And I don't know what the CBCL is.
Sure. So the CBCL is kind of a broad measure, kind of screener, or more broadly, a measure of all different types of behavioral and emotional difficulties that kids can have, and then group scores based off either DSM disorders and also just across general kind of scales of behavioral things like emotional reactivity, attention difficulties, aggressive behavior difficulties, mood difficulties, all those types of things. And then the Vanderbilt is a measure of ADHD symptoms and ODD symptoms, and then some kind of quick questions about anxiety and conduct disorder type symptoms. So I have teacher pulled up now. So teacher had reported 7 inattention symptoms of ADHD and 9 symptoms of hyperactivity, impulsivity. And the threshold for an ADHD diagnosis is 6 symptoms in either one or both of those categories. And then mom had reported 5 symptoms of inattention and I think 7 symptoms of hyperactivity, impulsivity. Yeah, 5 and 7. And then mom had reported 6 symptoms of oppositional defiant disorder, and teacher had reported 3. And then both had minimal anxiety concerns. And then on the CB,
Go ahead.
go ahead. I was going to say on the CBCL, that more broad measure looking across those different kind of diagnostic categories. The things that were jumping out were high rates of emotional reactivity, attention difficulties, and aggressive behavior. But the aggressive behavior is more so like emotional reactivity and impulse difficulty. So being really demanding or getting easily frustrated, having temper tantrums, being impulsive, those types of things.
That's really helpful. When was that done? That was at a pediatrician's office? Or with
So that was for his BMCP eval that I completed. And it was completed in December of 2021. So I don't know if they're still awaiting their BMCP evaluation, but it's part of the pre-visit screening that they do.
We were just noticing that they're scheduled to go see the Center for ADHD in the beginning, right before our ISS. So we will figure that out as we go. Because if BMCP is a better place for him, I'd hate to cancel visits and have him then back on a wait list for something that would be a good fit for him. So we can kind of work messaging the psychologist that he's scheduled to see. And then James, you're on this team, right? So we'll just be careful about not replicating things and making them do more paperwork than they need to do.
I might have missed this, but what were the behavior concerns that indicated this referral? Were there specific behaviors noted?
I couldn't find a note regarding like the physician. I don't know if anyone else did, but on the diagnosis that a provider can place, there were a couple of them. Let me see. Where did I put these?
I mean, the referral just says behavior problem in childhood, disruptive behavior, and
Yeah,
that's it.
disruptive behavior and a speech delay, but there was nothing specific.
Any other questions about Connor? Is that the right name?
Cooper.
Cooper, sorry. Cooper. I wanted to backtrack just a second to T1. So this is probably jumping a little bit ahead, but wondered from our like psychology and developmental pediatrician standpoint, mom in that case has a diagnosis of bipolar disorder. I wondered if you all could share, if someone could share with the group what bipolar disorder would look like in a young child and when that could potentially be diagnosed. I'm just curious.
I don't think I'm going to be able to answer this as specifically as I
I was going to
could.
say that is a loaded question, Dr. Girl.
So I wouldn't expect to see some of the symptoms that we would use to diagnose that in the DSM with an adult until later. Maybe more around adolescence, but maybe just looking for emotion dysregulation in general, low mood, and sort of that piece of maybe irritability. But I don't think that we would really see manic episodes that young, and I don't know if someone else can jump in on that. I would think it would be hard to pull apart from hyperactivity at his age.
Yeah, I mean, so technically for bipolar, you have to have episodes, like cyclic episodes. So I have never seen a 4-year-old that would be diagnosed with bipolar. And I feel like the earliest I've ever seen it in the clinical setting is like in teenagehood at the earliest, just because you need like discrete episodes of both depression and then like also mania or hypomania. So you need like discrete episodes, which is monitored over time, which is why I think we probably wouldn't see it. But I agree with Kate that it would probably present as kind of mood lability and more behavioral disturbance. But I think no one would probably diagnose it that young, and they would monitor. But it's definitely something to always think about because of the familial link in bipolar.
In previous training, I've been told that it's really rare to see bipolar onset so young without the hypersexuality component of it. And often that is like the thing that keys you into thinking of bipolar disorder when you're talking about kids who are that young.
I would echo all of that. I would just say that for me, bipolar disorder is always in the ballpark with reactive attachment disorder, that it's way overdiagnosed by people who shouldn't be diagnosing it and don't have the knowledge and experience to touch it. So, yeah.
Good to know. All right. Any other
However,
questions?
I want to take that to another step too, because I do think that there is something to be said, not just for the familial aspect of a diagnosis like bipolar disorder, but just the environmental. So when mom is in a depressed state, like that is going to impact the child's behavior as well. And so we, maybe we even want to gauge, how she feels that her diagnosis is being currently managed and if it's typical of what she sees at home and those kinds of things. Because if she's depressed, he may be depressed, or if she's depressed, maybe he's more hyperactive because he's trying to get her attention. Or if she's manic, maybe he's mimicking some of those symptoms. So I think that there's just a lot of maybe even some literature we could explore around bipolar disorder and parents and the impacts on kids, if that comes up. But if she's well managed, then yay, that's great, right? You know, if she feels like she's getting the supports and medication and therapies that she needs, that's the ideal.
I just had a question also for team one. With the outbursts and his violent behavior, has he always had this, or is this something that started after little sister came into, after being born, or is it something that maybe if dad's in and out of the picture, is it something that started then? Do we know any history on that?
The only thing I could see is that they listed those concerns in 2020 when they made the initial referral. So it's longer than the youngest sibling, at least, but I don't know if it's been his whole life. And in 2020, he would have been closer to 2 years old. So that's assuming that early developmental stage, at least.
Great question. And I really appreciate the further information about bipolar disorder in childhood, but also especially, you know, what Steph is bringing up about his environmental experiences with mom experiencing bipolar disorder. Any other things? Do you guys feel comfortable with the schedule for evaluations? I know, and Marta's already spoken a little bit about how this semester could be a bit trickier with the COVID ramp up right now. And also we always have a little bit of a harder time in the winter with weather conditions. So we can sometimes see cancellations for that reason. But Marta, do you want to speak to that any further?
So I've reached out to all the clinical supervisors to see if we have a game plan, if we need to reschedule for any reason. It's snowing, kids are sick, trainee's sick, supervisor's sick, and just trying to think ahead and just work ahead, plan ahead, because it makes my life a little less stressful and brings down my own anxiety when I have some sort of a game plan. So a lot of your supervisors have given me some feedback if they have protected time, when that time is. And so we might be doing some jumbling around. Hopefully everyone is healthy and it doesn't snow on a Tuesday morning. It just never happens that way. It always snows on a Tuesday morning, especially poor Team One's family who's traveling from very far. So even if like it doesn't snow much here, they might have a very different weather system. So stay in touch. However you stay in touch with your supervisor is fine. I will probably use email for last minute cancellation reschedule things, because I might be doing those from home as well, or your supervisors and I might be texting. If you would prefer something that's not email, let me know and I will try really, really hard, but check your children's emails the night before and the morning of your eval.
Yeah, and I would say we will try to make announcements on Canvas, but we can't guarantee it. The only thing we can guarantee is that Marta will email your children's email.
Anything else we should cover? Or is it time to head to breakout rooms? You guys good with breakout rooms? So you may or may not have things to talk about today, but if you do, you are welcome to go to your breakout room.
Oh, sorry, I had them built and you were supposed to be able to